Am I audible clearly now?
Yes.
Am I audible?
Yes, sir. You are audible, sir.
You are audible, sir.
Okay. No, I was just seeing the chat box that I wasn't properly audible. Okay. So
Yes, sir.
we can start the presentation.
Yes, sir. You just tell me when to change the slide.
Yeah. So you are having the controls, right? Okay.
Yes, sir.
Okay. So, on the outset, good evening, everyone, and I would thank MSD for providing an opportunity. I can say this is the first of the sort, right from my DM training and up to now, one of the first educational program MSD I have seen, and I would wish to continue the same. Today we are going to learn about checkpoint inhibitors and how to manage their toxicities. And in fact, MSD is one of the pioneers in a wonder drug called Pembrolizumab, which has revolutionized the way we look at cancer, which has changed cancer to a more of a chronic disease, just like diabetes and blood pressure, just to control the disease for a long period of time. So Merck has a big role in research and has completely changed the cancer management, especially in the advanced setting. And now we are having immunotherapies coming up in the neoadjuvant setting and the adjuvant setting, and in multiple areas. It has completely changed the outlook we have towards cancer treatment. So would congratulate Merck for that. Every day we can see the amount of research Merck has been doing, and every day, other day, a new trial has been there, and Pembro has its place almost at every cancer right now. So with this background of immune checkpoint inhibitors being introduced to cancer and entirely changing the outlook towards cancer management, let us proceed to understand what immunotherapy is all about and how do we manage their toxicities. Next slide. Yeah, next slide. So the slides are provided by MSD, and I have a disclaimer for that. Okay, next slide, please. Yeah, so this is a sequence. So basically, nowadays as medical oncologists, we all have learned how to administer immunotherapy, but because the experience is not that big because of what is called cost constraints, we are not able to recruit a large number of patients, and that's the reason why the experience is limited as far as the efficacy and also the side effect profile of immunotherapy is concerned. So it is even today we all have not handled the florid side effects of immunotherapy, and we're not actually so confident in handling the immune-related side effects than the chemo-related side effects, which are more predictive, and we have used it in volumes, and that's the reason why we are more confident in handling neuropathy or a neutropenia or a mucositis or a diarrhea associated with chemotherapy rather than that with immunotherapy, where it is unpredictable and we don't know when to act, when to stop, and when to administer steroids is the real confusion. So knowing how to handle the side effects of immunotherapy is extremely important, so that we stop the drug appropriately and we give appropriate drugs and we restart whenever it's required. Okay, next slide. Okay, next slide. Yeah. So this is the basic understanding of systemic therapy for cancer. We know surgery and radiation being an effective local therapy, and cytotoxic chemotherapy has been there with us. It acts on all proliferating cells. That's the reason why we see the efficacy of chemotherapy more in fast multiplying cells like leukemias, Burkitt lymphomas, or any high-grade malignancies, whereas we don't see that with low-grade diseases or diseases like liver cancer or renal cell carcinoma or pancreatic cancer, where the tissue is packed and we see only brief duration of action. So chemotherapy has its own limitations of it being active only on fast multiplying cells, and its prolonged action is overcome by resistance from the tumor or from the cancer cells, and the toxicity part. We cannot continue chemotherapy indefinitely because it has its cumulative toxicities. And when you come to targeted therapy, yes, targeted therapy does extremely well. It does target, but again, these targeted therapies also are known to have what is called off-target side effects. Like we have hand-foot syndrome, diarrhea, rash, and these are the multiple side effects which we see targeted therapy. And again, they're a little expensive. And again, cancer cells have learned to become resistant to targeted therapies. So we have VEGF targeted therapy, we have EGFR targeted therapy, we have targeted therapies like c-KIT mutations. So EGFR, ALK mutations, again they have shown promise. And then we have what is known as the immunotherapy or the checkpoint inhibitor therapy. So we are quite well convinced that cancer is an immunosuppressive disease. So we say of HIV or AIDS, it is an immunosuppressive disease, and cancer is not less than that. Cancer also weakens the immunity and has its own mechanisms of suppressing the immune system. So what it does is it causes what is known as T-cell anergy by various mechanisms, by expressing what are known as the programmed death ligands, PD-L1 expression. So it is basically the expression of the PD-L1 ligand that causes T-cell anergy and causes an immunosuppressive environment. So cancer is an immunosuppressive disease, and they are susceptible to multiple other infections. So with this background in mind, with understanding the differences between cytotoxic chemotherapy, targeted therapy, and the checkpoint inhibitor therapy, let us proceed further. And we have understood what is this PD-L1 all about. So PD-L1 is basically the ligand expressed on the tumor cells, which interacts with the programmed death receptor on the T cells and causes T cell death. So PD-L1 expression is a way of cancer cell overcoming or even killing the T cells which are otherwise cytotoxic to the tumor. Next slide. Yeah. So this is a very basic slide. This is what we always had, the slide where the tumor cell, how it overcomes the immune evasion. So basically, we always have a check in the body, what is known as immune surveillance, where the immune cells, especially the T cells, are in constant circulation to check whether the tumor is killed or not, and the tumor cells overcome this immune check or the immune surveillance by what is known as the PD-L1 expression or the CTLA4 expression. So the cytotoxic T lymphocyte 4 or the programmed death ligand expression, or the ways how the tumor cells overcome the immunity or cause tumor anergy or cause what is known as T cell anergy or weaken the immunity. So when the tumor has learned the art of killing the T cells, we have identified those targets. So what if we block the CTLA4 and the PD-L1? So CTLA4 and PD-L1 are the ligands expressed by the tumor cell to kill the T cells. So what if we block these ligands or the receptors? So then we can overcome what is known as tumor-induced T cell killing. So and then the T cells will become active and then they start killing the tumor cells. So we can tilt the balance to the other side just by blocking this particular pathway, or what we call as the immune checkpoint blockade. So if you prevent the killing of the T cell by the cancer cell, the T cell then becomes stronger and then it starts killing the tumor cell. So this is what is immunotherapy. So immunotherapy basically tilts the balance towards the side of strengthening the immunity and enriching the T cells, and the T cells would kill the tumor cells and prevent the cancer-induced T cell killing. So this is the whole thought process behind immunotherapy. So there is a problem with this. So if I block all the PD-1 or PD-L1, basically even the normal cells also have this expression of PD-1 or PD-L1, because the immune cells always keep checking the cancer shouldn't happen. So the normal cells also should not be killed by the immune cells. So the normal cells also express these PD-L1 and they prevent the immunity killing the normal cells. So once you tilt the balance, there can be a possibility of the immunity reacting on the normal cells, calling what is known as an autoimmune based phenomena. So we need to enrich the immunity to an extent of causing only cancer cell destruction. But if the immunity is so much activated or enriched, then there can be an autoimmune disease, again tilting the balance, where the immune cells can fight against our own cells, causing rash, causing pneumonitis, causing colitis, just like any autoimmune disease. We've heard of autoimmune diseases, SLE, ulcerative colitis. These are all autoimmune diseases. So, so these sort of phenomena can happen if you are giving immunotherapy. We are artificially inducing an autoimmune phenomena over here. So we want the immunity to be active to the extent of cancer cell destruction. When it becomes so active that it starts acting on our own cells, what we usually see is rash. Most common, we see diarrhea, and we see at times hypothyroidism, we see hypopituitarism. A lot of varieties of autoimmune phenomena are seen with cancer cells, with immunotherapy. So with this background, let us proceed further. Next slide. Yeah. So this is the immune-related adverse events I was saying. So I did mention about the PD-L1, the PD-1 blockade and the CTLA-4 blockade. So what I would specify is CTLA-4 blocking is by a drug called Ipilimumab, and we have a couple of more drugs coming in the market. But Ipilimumab as alone has not shown much promise in all the malignancies alone. In melanoma, it did show some promise, and now it's coming up in lung and kidney also. So, but alone CTLA-4 monotherapy has not been so efficacious. However, CTLA-4 blocking is sort of a dose dependent. If I'm using the high dose Ipilimumab, we see a lot of diarrhea and a grade 3 or even fatal diarrheas we see in nearly 50 to 60% patients with Ipilimumab. So CTLA-4 blocking is a problem because it causes a lot of colitis, and it's basically due to an autoimmune phenomena. So colitis is a big problem with what we face with CTLA-4. Whereas if we use PD-1 blockers, which is basically Pembrolizumab, Nivolumab, or PD-L1 blockers, Durvalumab, Atezolizumab, which we have. So these drugs where if we block the PD-1, PD-L1, the side effect is not that much. We do face a diarrhea, but the main problem is rash, and we face more of hypothyroidism and endocrine abnormalities. So CTLA-4 blocking alone, monotherapy is not that efficacious, not that promising. We need to combine CTLA-4 with PD-1, and CTLA-4 blocking with Ipilimumab is not only less efficacious, but also causes a lot of toxicities. So that's the reason why CTLA-4 blocking is not come in a big way, because of reduced efficacy and more toxicity. Whereas these PD-1, PD-L1 blockers have come in a big way, especially Pembrolizumab and Nivolumab have done a have revolutionized cancer treatment because they are more efficacious and also have less side effects. We usually see grade 3-4 side effects in less than 10% patients with PD-L1 blocking. So we have a drug which is extremely efficacious, and we have a drug which is less toxic. So that's the reason why PD-1 blockade or PD-L1 blockade has come in a big way. So next slide, please. Yeah. So this is the spectrum of side effects which we see. So to mention a few more things as far as immunotherapy is concerned. So if you look into chemotherapy, it is sort of dose dependent. I give a higher dose of chemotherapy, like we do an autologous stem cell transplant, where I give a supranormal dose of chemotherapy and try and kill even the stem cells, and so we have a sort of a dose-related effect, whereas that is not the case with immunotherapy. Here we are not trying to cause a direct cell shrinkage. On the other hand, we are trying to activate the immunity. So we don't know the exact dose of immunotherapy, even though we have approved doses of 3 milligram per kg or 240 flags of nivolumab, or we have 200 flags of pembrolizumab. So there have been a lot of exploration to reduce the dose of immunotherapy, and the frequency with chemotherapy is usually 3 weeks, because we want the bone marrow to recover and the blood count should normalize in 3 weeks. But the duration with immunotherapy, the frequency, again we don't know. Some drugs we use 3 weekly, some we use 2 weekly, some we use 4 weekly. So this is sort of a frequency. So the frequency and dose is sort of arbitrary. There have been studies where a lower dose is quite efficacious, and there are studies to the contrary also, where a proper dose, if not administered, would not be efficacious. So immunotherapy efficacy is not dose dependent, not frequency dependent, and chemotherapy stops working once we stop it. So like I give paclitaxel carboplatin for 6 cycles and I stop, and the cancer is going to come back in some time because it works for a brief duration. So basically chemotherapy stops working when we stop it, whereas immunotherapy is not like that. Once you have switched the immune mechanism on, the immunotherapy is going to be efficacious even after you stop the drug. So immunotherapy continues to act even after stopping it. So, and the other paradox or sort of understanding what we have is, in those patients in whom if we give immunotherapy and they develop a lot of autoimmune phenomena. For example, we had a lung cancer patient who developed a lot of autoimmune phenomena. He developed a lot of colitis, he developed nephritis, autoimmune hemolytic anemia. We could manage that by giving steroids, and those patients, we have a lot of side effects with immunotherapy do well as far as cancer is concerned. So we usually stop the drug once we have waiting for toxicities, the life-threatening toxicity with immunotherapy, and the moment we stop giving the drug, and the efficacy of immunotherapy sort of coincides with the amount of toxicities. So more if there are more autoimmune phenomena, it is indirectly saying that the immune switch has been switched on, and it is also acting on the cancer cell. So it is sort of a soft surrogate indicator that probably this patient is going to do well with cancer. So that makes more logical that we need to handle these side effects very well. So we have seen with a lot of chemotherapy in leukemias. So in leukemias, basically, we should have a lot of febrile neutropenia. The patient should become toxic, should develop a pneumonia. Then we say the patient is going to remission. If there are no side effects, not much of cytopenia, the nadir ANC is not reached, we say there is not much of remission. So sort of a similar thought process with immunotherapy also. If a patient develops rash, diarrhea, hypothyroidism, that means the immune mechanism has been switched on, and this patient is going to do well as far as cancer is concerned. So more of side effects, more of efficacy also as far as immunotherapy is concerned. So if you look into the spectrum of side effects which we have, it practically affects every part of the body. So we can this is something like an autoimmune phenomena, or you can see a graft versus host disease, or some sort of a thing. It's an artificial activation of T cells. You can see we can have endocrine side effects, hypothyroidism being the most common, hypophysitis less common, and diabetes. So we see a lot of hypothyroidism with PD-1 blockers, and it is very easy to manage. We do TSH or CTCAE levels, levels quite often. We do almost with every alternate cycle, we do TSH levels. So hypothyroidism is quite common. Thyroiditis is not that common. Hypophysitis is where the patient comes with fatigue, and hyponatremia, and this sort of a manifestation. There we see the TSH levels to be less than normal, We also do for cortisol levels and gonadotropin levels, all will be less. So hypophysitis, we also do an MRI to detect is there a hypophysitis there, and again, not bothersome to treat. We can treat all these endocrine complications by replacing with hormones. We give corticosteroids at physiological doses to replace. And then coming on to pneumonitis, pneumonitis is not that common. We see grade 3-4 pneumonitis in less than 10% patients, and the most important thing to pick up pneumonitis is early picking up. The moment patient has increasing cough, increasing dyspnea, should have a very low threshold for a HRCT chest, pick up the pneumonitis and start them on early steroids. So picking them up early and early administration of steroids are extremely important as far as pneumonitis is concerned. And not that common, but if it happens, it can be lethal. Hepatitis, not that common. We do see rate of transaminitis. We did have a patient of nivolumab or having florid hepatitis, did resolve with proper administration of steroids. Rash is extremely common. Having a Stevens-Johnson syndrome or a toxic epidermonecrolysis is not that common. We have seen a lot of rash happening. Nearly more than 50% patients have some sort of a rash, but we need to classify them into grade 1, 2, 3, 4. Is it life-threatening? Does it intervene with quality of life? Then we need to manage them properly. The other part, nephritis, not that common. We do urine protein. We monitor creatinine levels often. And then colitis is a problem, especially with ipilimumab, CTLA-4. Even with PD-1 blockers, it does happen. Again, picking up early, managing early matters. And the other rare side effects of arthritis, uveitis, myositis, UPS, myasthenia, vasculitis, hemolytic anemia, myocarditis, they are very rare. But if they happen, they can be very bothering. Again, having a very low clinical threshold, picking them up early, and fast administering steroids are extremely helpful. Next slide. Yeah. So this is the patient. There was a prior consensus saying that those patients who have autoimmune disease should not be administered immunotherapy. Later on, the studies came up saying that autoimmune diseases are not an absolute contraindication. However, we need to have a low threshold to stop the therapy and start on steroids or immunosuppressive therapy quite early. Then history of if the patient has grade 3-4 colitis with ipilimumab and giving a PD-1 blocker, again they will put them in high risk. So if you had a immune-related adverse effect in the previous type of immunotherapy, it's quite likely that you will have you're going to have an immune-related effect again with this new drug also. If there is a concurrent uncontrolled hepatitis, we all know HCC is basically HBV and HCV induced. Majority of patients, they do well. So if you have a proper viral load check and there is no active hepatitis, usually they are not that susceptible for hepatitis. But again, if you have an active hepatitis, then they can be patients who are going to have a lot of side effects. So the other drugs which intervene with metabolism may also have increasing incidence of adverse events. Next slide. Yeah, next slide, please. Yeah. So this is the routine investigations that we do. So how do we basically monitor the immune-related side effects? The most important way to pick up an immune-related adverse effect is to pick it early. So we need to have a low threshold. Just a little bit of itching means a lot to me when a patient is on immunotherapy. So whenever I see a side effect with immunotherapy, any complaint with the patient has a lot of fatigue, it means a lot to me when the patient is on immunotherapy. Just a little bit of itching cannot be ignored. The patient does multiple loose stools, again cannot be ignored. Increasing breathlessness, increasing cough cannot be ignored. So any symptom the patient comes to with has to be looked as if it is an immune-related adverse event. So we do understand that immunotherapy causes a slow benefit and is going to cause a long-standing benefit to these patients as far as anti-cancer therapies or the efficacy against cancer is concerned. Once you come to side effects, any complaint the patient has, like increasing breathlessness or an increasing cough, I cannot ignore. I cannot just get away by giving a course of antibiotics and let me see what needs to be done. I need to have a very low threshold to do a HRCT test and pick up, is it an immune-mediated pneumonitis? Because early administration of steroids actually prevents further damage. If I delay picking up pneumonitis, the fibrosis will set in and the patient becomes oxygen dependent and we lose the patient not because of cancer but because of immune-related adverse events. So that is number one. And as far as rash is concerned, again, we classify the rash into grade 1, 2, 3, depending on the percentage of body surface area involved. If it's less than 10%, 10 to 30%, more than 30%, and does it impair quality of life, and are there infections that are happening, and are there mucosal ulcers that are happening. So we need to always grade the side effect. And usually if we have a grade 1 side effect, we continue immunotherapy giving topical drugs like topical steroids or moisturizers, we continue. The moment it becomes grade 2, then the rule of thumb is I need to stop immunotherapy and give oral corticosteroids at around 0.5 to 1 milligram per kg. And I want a slow taper. I would taper around 6 weeks if it's a grade 2. The moment it becomes grade 3, then of course I will stop immunotherapy, number 1. Number 2, I would like to give intravenous corticosteroids. I prefer methylprednisolone. That is recommended than dexamethasone. So methylprednisolone is fast acting and prolonged acting, and that's the reason why methylprednisolone we give. Then we slowly taper on to prednisolone and then again slow taper. And the second line drugs we have are infliximab. So these are the drugs, again they're T-cell inhibitors, they come in the second line. And other T-cell inhibitors like mycophenolate mofetil, cyclosporin have also been tried. So these are the ways we start. The most important thing is to educate the patient before starting immunotherapy. We need to educate him about breathlessness, diarrhea, rash, and extreme fatigue. This will handle a majority of things. So if we educate the patient before, the patient will voluntarily come up with the complaints and we can pick these symptoms early. So basically grade 3, 4 side effects happen in less than 10% patients, but if it happens, they're going to be lethal. If we miss them, then the patient may come with a florid side effect, a florid pneumonitis or a florid shock if there is hypopituitarism, then we may lose the patient. So picking these side effects early, educating the patient even before starting immunotherapy, and the moment you suspect any such autoimmune phenomena, early starting steroids. If it is grade 1, we can continue. If it is grade 2, we need to stop immunotherapy and we need to start adding steroids early. So early administration of steroids, low threshold for diagnosis, and slow taper of steroids. So I should not be giving 3 doses of methylpred and send the patient home without steroids. I need to put them on maintenance steroids for at least 6 to 8 weeks. And there is no hurry to start the immunotherapy again. So these are the ways of thinking how to handle immune-related side effects. And the moment it is grade 2 or grade 3, I need to continue steroids or whatever immunosuppressive therapy I'm going to give for at least 4 to 6 weeks. And then I can restart the immunotherapy only when the side effect has returned back to grade 1 or less. If there is ongoing skin rash, ongoing colitis, I cannot restart the drug again. And there is no, when I'm restarting the drug, there is no question of dose reduction. I give 200 milligram pembrolizumab, I'll give 100 milligram the next cycle. That is not acceptable. Whether you give or you don't give, because the efficacy of the side effects are not dose related. So therefore, dose reduction is not the way to go. And giving immunotherapy on grade 2, 3 side effects is not the way to go. Early starting steroids and slow taper is the way to go. And if I have a patient with pneumonitis who is having grade 2, 3, and the patient has not improved with 1 day of methylprednisolone, I need to immediately start an infliximab on the second day, because we want to prevent the ongoing pneumonitis as early as possible. So stepping the immunosuppressive therapy to second line, especially in infliximab or mycophenolate mofetil, would be the way to go. So not to wait for 3 days, the patient is not improving, then think of adding infliximab. So picking or treating these late, we're going to lose the patient, because we've seen a lot of pneumonitis patient losing their life, not because of cancer, but because of immune-related side effects. So picking them early, stepping up the immunosuppressive therapy, starting them immediately if there is not much of efficacy with steroids, especially with methylprednisolone, then we need to start the second line, especially in infliximab or mycophenolate mofetil, to be started early. So if you can suppress the activated immunity early, then we can overcome the immune-mediated side effects. And there is no concern about the anti-cancer therapy. The immunity is already on. The cancer is taken care of. You need to balance the side effect part. If you can get the patient out of the side effect part, the patient is going to have a long-term survival as far as cancer is concerned. So this sort of thought process is required. So I'm not worried about hypothyroidism. Nothing much is required. You need to give a brief, if there is thyroiditis, give a brief course of steroid and put them on maintenance thyroxine. And again, with hypopituitarism, you need to take care of the cortisol part and make sure that the patient is not in shock. And again, give a brief course of steroids, can do an MRI brain and see is there hypophysitis going on. If not, you can start them on maintenance corticosteroids. So again, what about this maintenance corticosteroids in a patient with hypopituitarism? Will it weaken the immunotherapy efficacy? So the consensus is that if I can give prednisolone 10 milligrams per day, that's the replacement dose. That won't weaken the immunity part. So there's also been studies that what if I give these brief doses of immunosuppressive therapy, will it weaken the anti-cancer effective immunotherapy? There have been multiple studies that have shown that promptly treating the adverse events will not compromise on the anti-cancer efficacy. So these are the consensus. So we need not have to be guilty to start them on early steroids and proper tapering. So these are the sort of take-home messages that we can have when we are thinking of how to handle these immune-related adverse events. Next slide. Yeah, so this is how we monitor. We all know that we need to do an ECG for myocarditis. We need to do amylase lipase or pancreatitis when there is suspicion. And joint, we do all the factory of PRP, RA factors, we do all these tests before we come up. So we don't do all this routinely. We do clinical examination. We listen to the symptoms. We do these investigations only when clinically indicated. We do complete blood count. We do a TSH. We do LFTs, we do electrolytes at every visit, but routinely we don't do an echo or a ECG. We don't do routinely. Only when there is symptom-directed investigation is what we do. Next slide. Yeah. So this is what I was saying about the symptoms. Pneumonitis comes with these symptoms. Colitis comes with diarrhea, frequent bowel habit, blood in stool. Hepatitis comes with jaundice, transaminitis, endocrine, kidney, skin, I've already explained all this. Next slide. Next slide. So as I was saying we need to, whenever we have a side effect, we need to have a low threshold for picking it up, number one. Number two, I need to grade them, whether it is 1, 2, 3, 4, 5. You can see the CTCAE grading. This is the grading that we do in oncology. Because for me, if I say that the patient had diarrhea in the previous cycle, it doesn't mean anything to me. I want to know what is the grade of diarrhea. Is it grade 1, is up to 3 times where the patient has no symptoms at all? Whether it is grade 2, whether it is 3 to 7 times, or is it grade 3 more than 7 times, the patient required hospitalization. And grade 4 is life-threatening and grade 5 is death. So this is how we basically classify all the side effects by grades. If you take rash, for example, we grade rash by the surface area of involvement, less than 10%, 10 to 30%, or more than that. Does it involve the quality of life of the patient? Is he able to sleep at night, or is it so life-threatening that the patient requires admission because of secondary infection? So we always need to grade. So as a rule of thumb, to handle all immune-related adverse events, grade 1, I will give symptomatic treatment. There is rash, I'll give moisturizer, I'll give steroid lotions, and I will continue immunotherapy. The moment it is grade 2, I know it is intervening with its instrumental activities of daily living. There, I do not want to continue immunotherapy. I will stop the immunotherapy cycle and I will start them on symptomatic treatment plus oral steroids. Prednisolone 0.5 to 1 milligram per kg, and I would taper over a period of 4 to 6 weeks. There is no fast taper with steroids because the immunity is on and we need to take care of it. The moment it is grade 3 or admission is required, especially in case of pneumonitis, which we see grade 3, early starting intravenous methylprednisolone, and then once it is controlled, taper over with prednisolone over a period of 6 to 8 weeks. And with grade 3, it's our discretion whether we need to restart immunotherapy. Again, it's a balance between the risk and the benefit, but restart it not at a lesser dose. There is no question of dose reduction. Restart only when it has come back to grade 1 or less. Grade 4, no question of restarting, whatever it is. The autoimmune phenomenon is more than the cancer. There is no question of re-challenge. Okay, next slide. So this is again explained in this grade 1 toxicity, hold and symptomatic treatment. Grade 2, hold, give oral steroids. Next slide. Grade 3, intravenous steroids, infliximab. Grade 4, permanent discontinuation. Dose adjustment not recommended. Next slide. Next slide. So we know that Pembrolizumab, as I said you, is one of the wonder drugs that has revolutionized cancer management, almost in all malignancies, lung, melanoma, renal cell carcinoma, or in urothelial carcinoma. We have seen even in the non-metastatic setting, non-muscle invasive bladder cancer also it has a role now. So Pembrolizumab is a PD-1 blocker. And it is indicated as a monotherapy in non-small cell lung cancer if the PD-L1 is more than 50%. So regarding the biomarker for Pembrolizumab, so if you look into, if I give chemotherapy or a targeted therapy to 100 patients, I can say the responses will be around 60 to 70% if I have a disease which is chemosensitive. So I can say if I give chemotherapy, for example, if I take a head and neck cancer, if I give a taxane, platinum and cetuximab, I can say the response rate will be around 60 to 70%. And the problem with immunotherapy is not efficacious in 100% patients. It is efficacious only in 30%. And in those 30% patients in whom it is efficacious, it is going to be effective for long. It works in a small subset, and if it works, it's going to work for long, because this is not a dose-dependent efficacy. It is just switching the immune system on against cancer. So, but which are those subset of patients in whom it works? So, or do we have any biomarker to say that yes, these are expensive molecules. I cannot keep giving immunotherapy for all patients in whom, even though it is not efficacious. So is there a way for me to pick up which patient is going to benefit or which patient is not going to benefit? So for targeted therapies, we have excellent biomarkers. We have EGFR mutations. If there is EGFR mutation positive, I will give a gefitinib or a lotinib, otherwise I won't. With ALK positive, again, we have an excellent biomarker. But the unfortunate thing with immunotherapy is we don't have an excellent biomarker. We have surrogate biomarkers that suggest maybe it is effective, or the chances of it being efficacious is high. So how do we assess it? So we can see what is the PD-L1 expression. If the tumor has a PD-L1 expression, then maybe it is efficacious. But just a mere PD-L1 expression is not enough. I want the tumor cell to express PD-L1. At the same time, there should be an immune cell being present at the same time. This is what we call as the combined positive score, or the total positive score, what I call. So not just the mere expression of PD-L1 by the tumor cell. At the same time, I want the immune cell to be present at the same time. So both this combination is what is called as the combined positive score or the TPS, what we call, is what we need to have a biomarker. Next slide. Yeah. So this is a study in more than 2,700 patients with melanoma, a huge data, and the median treatment duration was 4.2 months, and the pembrolizumab discontinued. That is, they had grade 3-4 toxicities due to, and it was only in 5% patients. So this just reassures us that it is not that toxic drug, because 95% patients did not require discontinuation because of toxicity. That means it's a safe enough drug than chemotherapy. You can see the side effects are pneumonitis, colitis, diarrhea, and pyrexia. Next slide. Again, you can see, as I was mentioning, thyroid problems are the more common with the PD-1, PD-L1 blockers, whereas colitis is more common with the CTLA-4 blockers. The other side effects like hypophysitis, nephritis, colitis are less common. You can see the numbers. So we are more worried of grade 3-4 complications. You can see it is 0.1%, 0.1%, and less than 1%. So these are well tolerated drugs. They have less side effects. They are more efficacious. They're efficacious in a small set of population, and if they are efficacious, their side effect profile is excellent when compared to chemotherapy. Next slide. So these are the trials that included, there were some rare side effects. We did have a patient with myocarditis, patients with uveitis, myositis, GPS. They're rare, but we need to have a low threshold for suspicion. But they're extremely rare. They're seen in less than 2%, less than 1% population. Next slide. So this is an excellent slide that says what is the median duration of onset of side effects. Previous slide. Yeah. So you can see pneumonitis happens at around 3 months, colitis happens around 3.5 months, hepatitis happens quite early, around 1.3 months, and hypophysitis happens at around 3.7 months, and hypothyroidism happens at 1.4 months, hypo happens at 3.5 months, and nephritis happens at 5.1 months. So these are the side effects, approximate timelines when we can expect side effects. And you can see the duration through which it lasts. You can see endocrine side effects are quite permanent and they last for long. Whereas the other one settle with treatment. Colitis settles fast with proper treatment. Pneumonitis settles fast with proper treatment. So endocrine side effects are not a problem because the only thing we need to do is supplementation of hormones. Next slide. Yeah. This is the reason for discontinuation. Pneumonitis is one of the dreaded complications we have because once pneumonitis sets in, it is very difficult to reverse it. The patient, we usually lose the patient and we need to discontinue once the pneumonitis is set in. Next slide. Next slide. Yeah. So again, what I said has been again reiterated that grade 1, 2, 3, 4 we need to monitor and appropriately administer immunosuppressive therapy. Next slide. Yeah. Similar. Next slide. Yeah. So I think with this I can conclude with a few take-home messages. So number one, immunotherapy has revolutionized anti-cancer treatment. It has changed cancer into a more chronic disease where the patient, we never had lung cancer patients crossing 2 years, 3 years mark, but now we can see lung cancer patients crossing 3 years and select 30% patients even crossing 5 years. Dreaded diseases like melanoma, RCC, urinary bladder cancer living long. So we are able to see dreaded cancer patients living longer than we had never seen. So activating immune system was the best way to go and we have picked it up, number one. Number two, efficacy of immunotherapy is not dose dependent. The doses are arbitrary, the frequency is arbitrary. Having said that, we need to follow whatever guidelines are there. And number three, the efficacy of immunotherapy continues even after you stop it. Number four, immune-related adverse events happen, but grade 3, 4 or those which require hospitalization, those which is life-threatening, happens in less than 10% patients or even less than 5% patients. But in those patients in whom it happens, the anti-cancer efficacy also is proportionately better. So we need to pick these immune-related adverse events quite early. So educating the patient about side effects before starting treatment, picking the side effects. So picking the side effects early administration of corticosteroids, grading the side effects into grade 1, 2, 3, 4. So the moment it is grade 1, just stop the immunotherapy, continue supportive therapy. The moment it becomes grade 2, I would stop the immunotherapy, give oral steroids for a brief duration and taper over 6 weeks. At the moment it is grade 3 or 4 where the patient requires hospitalization, we need to start on intravenous methyl prednisolone and then slowly taper with switching over to oral steroids over a period of 6 to 8 weeks. And if there is no response to intravenous corticosteroids, then we need to start them on other T-cell suppressive therapies like mycophenolate or cyclosporin or infliximab, which is an anti-INF. Early starting on steroids and slow taper is the way to go. So with this, I would conclude, and I would be happy to take any questions. And I'm happy to see all my friends being there, and thanks a lot for your patient hearing. Thank you.